Playbook webinar made possible through the 7 Foundation Collaborative on integrating bridge clinics into emergency departments to facilitate access to opioid use disorders. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, audio lines are being muted during today's event. There will be a moderated question and answer session following today's presentations. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and shared publicly on bettercareplaybook.org. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope that you'll take a moment to do this. I'll now turn the webinar over to Carla Silverman, Associate Director at the Center for Healthcare Strategies.
Thank you so much, Travis. I'm Carla Silverman, Associate Director for Complex Care Delivery at the Center for Healthcare Strategies. And so excited to have you all here today for integrating bridge clinics into emergency departments to facilitate access to opioid use disorders. Next slide, please. Today, we will have a presentation from our esteemed panelists, and then we will be having a Q&A. We really encourage all of you in the audience to submit your questions to the Q&A section as people are speaking and afterwards, and we will do our best to answer them during the session. Next slide, please. So I'd like to provide just a brief background on the Better Care Playbook for those who may not be familiar with it. The Playbook is an online resource center for evidence-based and promising practices to improve care for people with complex health and social needs. Every month, the Playbook summarizes new journal articles, evaluations, and implementation tools. The Playbook also develops resources like this webinar designed to help translate evidence and research into practice. You can explore the playbook at bettercareplaybook.org. Next slide, please. The playbook is coordinated by the Center for Healthcare Strategies through support from 7 leading national healthcare foundations, including Arnold Ventures, the Commonwealth Fund, the John A. Hartford Foundation, the Milbank Memorial Fund, Peterson Center on Healthcare, the Robert Wood Johnson Foundation, and the SCAN Foundation. Next slide, please. So I'd like to provide a little context for the discussion that we're going to have today. As many of you are likely aware, the overdose epidemic is worsening in this country. Deaths involving synthetic opioids, primarily fentanyl, continue to rise. In 2020, we saw 56,000 deaths due to opioid use disorder overdose. We estimate, or it is estimated, that 7 million people in the US are living with opioid use disorder. Most are not receiving evidence-based treatment, and there is an urgent need for greater access to treatment that really meets people where they are at. This includes prioritizing rapid access to medications for addiction treatment, and it means reaching people at the various touch points where they intersect with medical settings. Bridge clinics use interdisciplinary teams to support high-risk post-discharge patients with substance use disorder. I also want to mention that the Playbook has recently developed an addiction care collection of resources to provide a broad, although not exhaustive, overview of some of the innovative models for providers and policymakers who are interested in understanding the growing evidence for these models. Those include case studies and implementation tools. And I think one of my colleagues has shared the link in the chat. Yes, thank you. Next slide, please. So I'm really pleased to introduce our 3 presenters who will describe the California Bridge model for integrating bridge programs into emergency departments and walk through perspectives on implementation from their various roles as a clinician, substance use disorder navigator, and a hospital CEO. Their perspective on how to develop this model and how to rapidly expand this model across a state can offer valuable lessons for providers, policymakers, community partners, and others who are looking to improve addiction care and address the overdose crisis. Today's panelists are Ariana Campbell, who is a physician assistant and director and co-principal investigator for California Bridge at the Marshall Medical Center. We also have Wendy Martinez, who's a substance use navigator, mentor at the California Bridge, and she is at the Arrowhead Regional Medical Center. And finally, we have Siri Nelson, who is the Chief Executive Officer at Marshall Medical Center. So at this point, I'd like to turn the session over to Ariana to begin her presentation. Thank you.
All right, great. Thank you so much, Carla, and thank you to everybody at the Playbook for including us in this series, because I really feel like this is very important to talk about, and very honored to be here with my own hospital CEO, Siri Nelson, and extremely happy to be here also with Wendy Martinez, who's was one of our foundational substance use navigators and is providing mentorship to other navigators across the state of California. So let's get into it. Next slide. I don't have any disclosures. I do have to say that the work we do at Bridge, and yes, we have California Bridge, which is our work in California, and we have Bridge, which is our national work, but we are funded through the Department of Healthcare Services, specifically for our California work. And then the work that we're doing across the country is funded by the Opioid Response Network and the FOR Foundation. And we're extremely grateful to them so we can get all of this information out to people. All right, next slide. So just a little word on Bridge, and we'll talk a little bit more about it. But the reason we're here today is because my hospital was one of the first 4 hospitals in the state to really do this, to address opioid use disorder in the hospital and emergency department setting. And we're very proud of that. And we knew that the work we were doing is incredibly important. We wanted to make sure that all hospitals in California were doing this. And the reason is we wanted to create this wave that changed the standard of care. And it was unacceptable for it to take too long to do this. Meaning we knew that practice change takes years and years and years. People are dying. People are dying at high rates, to Carla's point. So it was very important to us that we got the word out, because what we're doing in emergency departments is so important, and it can really change the tide of this. All right, so we've done this all across California. And in the next slide, I'll show you why this is so important. So Carla, you addressed this a little bit, but yes, we saw more than 55,000 deaths from opioids specifically, more than 100,000 deaths actually if you go through 2020, and this was actually more than 107,000 deaths in 2021. And what you can see here, the reason I wanted to put the slide up is because you can see all opioids, right? This all opioids line, that's that blue line there. You can see all drugs, but look at that dark line. That is fentanyl. And so what we do know is that fentanyl is causing this significant surge in overdose deaths. I mean, we have seen a decrease in life expectancy in the last few years by 3 years, which is very significant. This is the biggest decrease in life expectancy in a decade, or no, actually in 100 years. So it's really important to address this now and to do this with urgency. And what better place to do this than emergency departments? So next slide. This is the deal. So what we need to do is fund and support programs that are innovating and increased in capacity immediately, because only 10% of folks with substance use disorder receive any treatment at all. And of those who receive treatment, 87% do not receive evidence-based treatment specifically for opioid use disorder. And we have evidence out there. We know that we can prevent these deaths. So this is why we need to increase this capacity now. And that combination of emergency departments paired with bridge clinics can really turn the tide. So we'll talk about that. Next slide. Again, the reason that we have to increase capacity, meaning not just funding the same type of things or supporting the same type of things we've had. Of course, we want to continue those, but we have to immediately increase capacity, because my experience, I've been an emergency department PA now for more than 22 years, going on 23 years. And what I can tell you is for 17 years, what this looked like is when somebody came to me and wanted help with opioid use disorder, if they were brave enough to tell me about that, then unfortunately they were met with long waiting periods to get into any facility that would take them to help them out. Complex assessments, they would have to jump through a lot of hoops. And while they were potentially in withdrawal, in order to get care, they would be referred to specialty care. We all know what it's like to be referred to specialty care. It can take months. There's insurance authorizations, rigid treatment contracts that were just unreasonable. And unfortunately, folks were met with a lot of stigma and moral judgment. If you, let's say, I compare this sometimes to, like, let's say you're experiencing chest pain. If you thought that you went to a hospital emergency department and they would tell you, this is the wrong place for you, and then judge you and treat you poorly. Or if you went to your doctor's office and you had high blood pressure and you were going to be treated poorly, why would you go? You wouldn't want to go. So it's really important that just at the very base of everything, that we treat people well. And the current system needs to change so that we make sure people feel accepted into medical treatment. So next slide. So we came up with the California Bridge model because this doesn't have to be rocket science. You can start this. I know that there's a lot of folks from states, across the country, from different systems, and this can be done now. The program that we started at Marshall Medical Center, we started because we saw a need. We saw that there was not capacity to treat folks, and we needed to increase that capacity. And emergency departments, when they take this on, make it safe for the community. I can tell you, if anything goes wrong, people want to know that the emergency department and hospital can support patients and can support the providers in the community, because we do that for every other medical problem. So we came up with this model to really make it easy for people to start treating out of the emergency department and hospital. And when we carry this over to bridge clinics, and we'll talk more about bridge clinics, I know Carla talked a little bit about them at first. When we carry this over, it can create this acceptance, this capacity that's increased immediately, and people can get real care. So what this looks like is low barrier treatment, making sure that people know they don't have to jump through 5,000 hoops to get treatment, meaning we want to make it easier to access medical treatment than for somebody to get drugs from the street. That would be the dream. That would be the goal. And that's where we're trying to head. Then we need to make sure that folks are connected to community and resources in community. There are so many amazing people in my community who are doing great work. We want to make sure that all of that is connected to the people that I run into the emergency department, because a lot of the people I treat in the emergency department are not otherwise connected to care. They may not be, in fact, many are not accessing the traditional medical system. And we want to promote a culture of harm reduction. We should be doing this in everything we ever encounter in medicine, just this culture of reducing harm. Not everybody takes their blood pressure medication like they should. Not everybody takes their diabetes medications like they should. And not everybody is interested in treatment for their substance use disorder at any one time. So what we need to do is promote this culture of harm reduction into everyday practice in medicine so that we give people a chance. We give people a chance to make it through a tough time in their life without infectious diseases, without endocarditis, without a lot of the things that could cause lifelong problems for people. So in this next slide, I'm going to talk a little bit more about why buprenorphine, and I'm going to name buprenorphine specifically because this is what we're giving. And when I talk about treatment, just to be clear, we're usually giving buprenorphine in emergency departments. We also sometimes give methadone. In my community, access to methadone is very challenging. And so we're primarily giving buprenorphine, especially because we like the safety of buprenorphine and we feel really good about giving this medication because it has a ceiling effect on stopping breathing, right? So we like to keep people breathing, and it's easy for us to give to somebody. We love ease of use in the emergency department. Even if somebody's feeling sick or, nauseous, we're able to give this and it dissolves in their mouth, and it's long acting and it outcompetes all of the other opioids for that receptor in the brain. And we really like that. So, again, I do this all the time in my emergency department, and it's amazing how stabilizing folks in treatment gives them a chance to change their life. And I see this all the time. All right, so again, we can reduce the risk of death tenfold by getting somebody on buprenorphine. So this is really important to know. Next slide. And when we do this in the emergency department setting, this is Gail D'Onofrio's study from Yale from 2015, published in JAMA. What we do know is that when we are able to give this medication, this medication that dissolves in the mouth in the emergency department, we double a person's likelihood of being in treatment in 1 month. So that same medication that reduces their risk of dying tenfold, and then we just simply give the right medication at the right time in the emergency department, and it doubles their likelihood of being in treatment in 1 month. That is significant, especially when we know that when a post-overdose, a person's risk of dying from any cause, or actually a person's risk of dying specifically for overdose, this is Scott Weiner's article from Massachusetts, their risk of dying is 5.5%. These are people who by and large are young people, many of them, in fact, the majority under 35, who have a really high risk of dying in the next year after a non-fatal overdose. It's pretty similar actually to heart attacks. So this really requires our attention, and we have to acknowledge that the overdose epidemic is emergency department related by nature, in that we see overdoses primarily in our emergency departments. All right, so next slide. So again, I've gone over most of the points of why emergency departments are so important in this, but it's the ultimate safety net. We all see, you're driving down the freeway, you see the H, there's a hospital. We want to make it easy for people to navigate a very complex system to get care. And there is a moment. My folks who come to me in my emergency department, there is a moment where they have decided they want treatment. They want a way out. They don't want to continue using. And if we can capture them in that moment and create frictionless access, that can change their life. But if we make it too hard, if it takes too much to figure out where to go, I sometimes have trouble figuring out how to access medical care for my kids, right? So it can be very challenging, but if we can make it really easy, again, we can really change people's lives. And we wanted in California to make it look like, hey, you can go to any emergency department and expect to get high quality care. Just like if you cut your hand, right? You can go to the local emergency department. We wanted to make it that easy. And we want to recognize that we can also do other things. So if somebody is experiencing a psychiatric emergency at the same time, we're able to provide stabilization for all of this, because you know what? It's one human being in front of me who may have different challenges, and addressing those challenges in that moment when that person is contemplating change is very, very important. All right, so in this next slide, I'm going to turn this over to Wendy Martinez, because she is the expert on substance use navigation, and I'm very proud. Her position was a dream come true, knowing that we have people working in emergency departments across California to make folks feel safe and to connect them to care. It's creating this rapid change. So Wendy, tell us a little bit about navigation.
Thank you, Ariana, and thank you to everyone here for having us get this important message out. I am a substance use navigator and substance use navigator mentor. And our two primary sorry, I'm getting a little nervous. Our two primary job duties are linking patients to ongoing care and active support follow-up. And active support, meaning that we are communicating with these patients, we are sitting next to them, we are looking them in the eye, we are making sure that they feel supported while they are in the emergency room. We want to make them feel comfortable. And, if they're hungry, if it's appropriate for them to have food, if they don't have any other ailments going on, we're going to do that. If they're cold, get them a blanket, and kind of ease their fear, because a lot of them are scared when they come in and they think they'll go to jail. And so we just want to be there to support them. We also reach out to community organizations and to have a referral system for these patients once they're discharged from the hospital, and also to our local harm reduction, our Department of Public Health. We want to make sure that there is support in the community and near the patient's home. So depending on what cities they live in, we want to make sure that not only are they receiving low barrier treatment, but the access and the transportation is there as well. And it's not, they're not going to have to drive, 50 miles every day to receive treatment. Next slide, please. So the way that this looks in a hospital for the California Bridge model is that a patient will come in. They may be coming in for something that has nothing to do with being in withdrawal, but once they are in, our clinical champion will provide assistance to staff and support with dosing, with medication dosing. If there are other staff members that are not quite familiar with it. But once they're identified as being in withdrawal, they'll be given the medication. A consult will be put in for a substance use navigator to speak with the patient to give them guidance and link them to ongoing low barrier treatment. And also, if the patient is not ready to make that change, the navigator is going to provide harm reduction information to the patient. And then if they are ready for treatment and they're able to be induced in the emergency room, then the substance use navigator will link the patient to ongoing treatment, make sure they have a prescription up until their appointment date, and they just have a better outcome, and there's lower readmissions, and it's just all around a caring environment and supportive environment for the patients to continue treatment. Next slide, please. Patient navigation is also cost effective. There has been studies shown that when you have a dual diagnosis patient, which is, I want to say, most of the patients that come in, you can save money and save your hospital money per participant. It also, inpatient admission rates also lower by 26%. And 50% of patients engaged in SUD treatment are compared only to 30% of the control arm. So after discharge, it's that you're going to have less reoccurring visits. You might have the patient come in, let's say 3 months down the line if they relapse, but for the most part, once they've started on buprenorphine, they have an overwhelming sense of feeling quote unquote normal. And so when they do relapse, they tend to remember that feeling that they had. And then usually I will not see a patient again after a first relapse, if they even have one. Most of them just need that support and guidance. And I also provide them with any other resources that they may need for housing and whatnot. Next slide, please. We have our bridge clinics that we use. And for my hospital, we have our SAC Norton clinic, but initially SUNS will reach out into their community and call around to like Department of Public Health, to AGIS centers, any type of clinic that offers substance use treatment. We go out into the community and meet with these community partners to set up low barrier treatment and make those phone calls to see what's the patient going to need when I send them here. Do they need an ID? Is a paper ID okay? Because some of them only have a paper ID from the DMV. Different things like that. What insurance is accepted at these places. So that way, we're not just sending them out there blindly. We actually have the information and everything all sorted out for them. So most of the time we're sending them, all they have to do is show up and just have that support through the clinic, and always to know that they can contact the SUN if they have any issues with a bridge clinic, or they don't feel like they're being treated fairly. Next slide, please. So the culture that we create is a welcoming culture where we try to use language that does not is not offensive. We don't want to be calling people junkies. Oh, you know, that there's a culture that has been in the emergency room forever with, you know, you have people who are quote unquote drug seeking. And we want, as son mentors and sons, we want to change the culture in the hospital to using more harm reduction led language, such as saying people who use drugs versus, you know, a drug seeker, you know, substance use versus substance abuse. And we also promote harm reduction and trauma-informed care practices by making sure that for our dual diagnosis patients that we do have a mental health screening involved in their care while they're here in the emergency room if it's needed. And then we just build trust. Looking a patient in the eye, it means a lot to them. I have a lot of patients who will say, "You're the first person who's looked me in the eye and talked to me in years." And just little things like that, and having just respect for another human being is what this program is all about. And it's very, very, I'm very passionate about my work, and it's very fulfilling to me. Next slide, please. So for harm reduction, we have a naloxone distribution program that we have our gurus at California Bridge who can help you with this. Josh Luftig and Charles Hawthorne can assist in this program, but it's available to everyone and anyone. You can order Narcan for your hospital, your clinic. I have a pastor who's reached out to me because he helps a lot of homeless people that I distribute naloxone to so he can have it. And we definitely want everyone to leave with naloxone. And if you don't have a program yet, please encourage providers to at least prescribe it for them. There are some Walgreens that will give a naloxone if to a person for free. You just have to search those out because not every Walgreens does it. And then if you have a local harm reduction site near you, you can always refer the patients to the local harm reduction to get some Narcan if they end up using theirs and they don't necessarily want to come into the emergency room to get one. You can refer them to your local harm reduction site or any other sites that that have a naloxone distribution program. And next slide. And I believe I'm gonna pass it back off to Ariana. Thank you, everyone.
Perfect. Thank you. Thank you so much, Wendy. And it's really important to hear from one of our navigators, right? So this slide is just to show you exactly where we are placing navigators and starting programs. And we set out to do this really quickly. Again, there's an urgency to this that we were feeling, and we just really wanted to make sure we increased capacity in California. And so through this slide, you can see how rapidly we did this. So we started again with just 4 hospitals who were giving buprenorphine back in 2017. In a pretty short period of time, we've scaled this. And what I can tell you is first, we had a first 52 hospitals that we funded. Somebody had to ask this question. We gave them some funding to fund a navigator and a champion. And that's a recipe that worked because all 52 of our initial sites were able to start treating in 2018, 2019, and you can see how rapidly that expanded. So then the state of California did a line item in the budget for navigators, just like Wendy, at more hospitals in California, and we increased to 200. So this model of care in 200 hospitals. And more recently, there was another line item to support navigators and champions in all hospitals in California. And to date, we have more than 260 hospitals. So the vast majority, in fact, we are at around 85% now of hospitals who are at some stage of implementation of giving buprenorphine in the emergency department, having a navigator in the emergency department, and referring to local care. And a lot of questions people have for me is, how are you connecting them to care in the community? Yes, what if the emergency department takes this on? Is there somewhere in the community that they can go? The answer is yes, we've found places, but we sometimes have to be creative at first to get programs started. And I can tell you, we started with our local FQHC, but Marshall saw the value of this. My hospital saw the value of this, and I'll have Siri talking a little bit about that. But so then we actually developed our own bridge clinic. And I know that's what a lot of folks wanted to hear about, were these bridge clinics, because we found that folks wanted low barrier, really easy access to care and no closed doors. And so having actually a bridge clinic on the campus of our hospital, like right across the street, has been really helpful for patients. So again, looking at this rapid expansion, these are all sites we have successfully implemented in all these sites. Are they all perfect? Of course not. Once you start doing this work, you can find that there's more things to do to provide better care for people. But this is a starting point, and we've actually brought this into our quality department. So let's go to this next slide. You can see, are all these people giving buprenorphine? And yes, if you want to change the landscape of addiction treatment in your state, then I certainly recommend absolutely engaging your hospitals and emergency departments. Why? In a relatively short period of time, we were able to identify a lot of folks with substance use disorders. In fact, the stat is pretty close to about 1 in 4 screen positive for a substance use disorder in the emergency department at any one time, even if that's not their chief complaint, the primary reason for being there. But through this work, we were able to identify, this is actually through 2021, so not even including now. These numbers are much bigger now because we've rapidly expanded, but almost 134,000 folks identified with opioid use disorder. I hear all the time people say, well, we don't have that problem in my community. Trust me, I said the same thing. The problem is in your community. It's just they may not feel safe disclosing this in your hospital or emergency department. We were able to provide appropriate medication for people through emergency departments to more than 62,000 folks. And this is much bigger now. And then if you want to get naloxone out in your state, give it to the emergency departments. We have in-hand naloxone programs at most of the sites in our state now. And we've actually exceeded 100,000 boxes of naloxone being handed out in my own community. To bring this back, what that looks like is we saw more than 40 overdose deaths in this last year, but we know we have information that the naloxone that we provided in hand to people in our emergency department reversed at least 58 to 60 overdoses. So we would have had more than twice that without giving in-hand naloxone. So very important to get naloxone into the hands of folks through emergency departments. All right, next slide. I know that there's a lot of folks from across the country on this call, and we are doing work across the country. In fact, we're trying to develop a network of people from every single state so that we have this connection, because we found that connecting all the dots is really important in this work. So we are working we just worked in Louisiana, we're doing some work in Nevada, bringing it to Oklahoma. So there's a lot of work that we're doing right now, again, through the FOR Foundation and through the Opioid Response Network, to create a national bridge network and to help a lot of the states who may be struggling to get this into emergency departments. I always say we try to unstick people from where they got stuck, because this is, again, really the best type of treatment that you can do in the emergency department. And then next slide. And we don't rest, because we're very concerned that there's been a prediction that there's more than 1 million overdose deaths predicted in the next 10 years. This was out of an article, and I highly recommend it, through the Lancet with a Stanford commission. They partnered and gave some policy recommendations on what we can do to reverse these trends. And I highly recommend that article. It's really great information. All right, next slide. I'm going to now talk a little bit about specifically Marshall Medical Center. So what we saw at Marshall Medical Center is we have this timeline. I talked a little bit about it, and I'm going to use this as just a site example to give you just a more realistic picture of what this can look like. So we got buprenorphine on formulary in 2017, and it was not hard. It's an obvious medication. If you do not have this in your hospital on formulary, even if you're not doing this through your emergency department, you need to continue folks on buprenorphine. This should absolutely be on formulary. And then we actually this is back when it took a lot of education to get your X waiver. So we got our PAs X waivered. And I can just tell you, I gave them a due date and they got it done. It's like counting to 3. If you give somebody, when I count to 3 with my kids, things happen. When I gave people a due date, they got their X waiver. Just for people, the DATA 2000 X waiver is something that you need in order to prescribe buprenorphine. You do not need it to administer buprenorphine in the emergency department or hospital setting, just to be clear. But we did all of this in 2017, and within 6 weeks, we were treating people. So we didn't have this perfect program. We didn't have a navigator. We were just giving the right medication at the right time to folks. And it was pretty successful, actually. We had a very high follow-up rate even initially. It was more than 70%. And then we actually developed, we got a navigator. So if you look at this timeline, in 2019, we had a substance use navigator like Wendy in our emergency department. And you can just see that we were, and then our clinic, the CARES clinic, opened, and we were able to expand what we were able to do. And in fact, we increased how much opioid use disorder that diagnosis we were making, and we were increasing how much buprenorphine we were giving. And then again, we actually had at least half of our providers get their X waiver because they realized this is actually easier to be able to prescribe it to people. So it's better to get your X waiver. And then we brought on a project coordinator who we developed a substance use disorder committee. And this is all kind of in that quality. We started building quality. And then we had another substance use navigator who was hired on because one of my first substance use navigator is doing a lot of harm reduction in our community. So saw a need there and a gap in care. And again, we're a rural community in northeastern California, and we're making this happen. So in this next slide, you'll see exactly where we're located. I always say we're at like the elbow of California, but I want you to now see, so this is how we expanded treatment. And a lot of this has to do with that tight connection between the bridge clinic and the hospital, in that we were able to provide increased capacity in our small community. But we are a rural community. In fact, a lot of the places are 45 minutes away from the hospital. So we want to make it easy and visible. This is just a picture of me with my substance use navigator, and not my favorite picture of me, but I was on shift. And there is just that we want to show that we have signage. You walk through the door. If you are a person who with opioid use disorder and you walk into my emergency department, the first thing that you're going to see is this sign sitting there that's making it safe for you to talk to us about it. It says, are you struggling with pills, heroin? We need to update it to fentanyl. We can help you. And just establishing that this is a safe place to talk about this, that's actually really important. You can't see it on my badge, but I have on my badge, I said, you can talk to me about drugs, no shame, no judgment, like I've got you. And so if a person walks in, they will see this and know that initially they are able to get care. We have done a Stigma course for all of my emergency department nurses, even registration staff. So when the person comes in and says, I'm in withdrawal, we treat them well. And if you did nothing else, treat people well. That is so important. So, okay, we can help you with that. My navigator has access to my EMR. She may see that somebody just checked in who's struggling with any substance, really. And so frequently she's seeing them right when they walk in, like in the waiting room, she's already connecting with that person. My triage nurse knows that we can treat this. Will make the appropriate chief complaint, say, person is seeking, or is it an opioid withdrawal? We can identify that on the back end. We have we're on Epic. And so my navigator, if we're incredibly busy, which is much of the time, she is able to come to me and say, hey, this person's really struggling. I think they need medication. Can you just run in and do a quick assessment? And so I can run in and she gives me all of the pertinent information, and I can assess the patient to see if they're ready for medication. Then my nurses, we have done a lot of education with my nurses, and we're continuing to expand that, but they know it's important to give this medication quickly. So we give a good dose of it to make sure that we get people out of withdrawal. We don't require any labs. We don't require urine drug screens. We call urine liquid gold. It's hard to get in the ER sometimes. And so we just treat them for what they came in for. And most of them get much better. The only drug in our community right now for opioids is fentanyl. You know, it's all fentanyl right now. So, but we're able to educate people if they are not in enough withdrawal. All of my emergency department clinicians have X waivers. We are all able to prescribe buprenorphine. And so if they're not ready, we can give them a prescription and they can start at home. My navigator is working on the back end to make sure that they have an appointment time, address any transportation issues, and make sure that that person can get to treatment. And then they leave, hopefully feeling normal. In fact, most of them feel totally back to normal when they leave. They have a prescription, couple boxes of naloxone in hand, and they follow up at the clinic. My navigator will reach out to them and make sure that they got to the clinic. She'll reach out to them sometimes if a week later, a month later, a few months later, and just check in and make sure that they are doing well. That's what it can look like. And the person feels wrapped in care. So next slide. So when you have a program like this, what can it look like? Retention and treatment. So by and large, I think about 30% is follow-up for this across the country, which isn't bad. You think of all the other medical problems, but if you can click it again, I'm going to show you for all substances in my emergency department, because somebody had asked us in the chat, what about all substances? Our follow-up rate when we're giving medication for addiction treatment is high. So over 70% for all, this is like alcohol, stimulants, and because we are treating stimulant use disorder in my emergency department and opioid use disorder. But click on the next one, you'll be able to see specifically for opioid use disorder. Look at that blue line, Q1, with a lot of probably New Year's resolutions. We had a follow-up rate of 94%, right? That's huge. I mean, what other medical problem do we have that kind of follow-up? But we've maintained above 80% and above, even in different quarters. And this is because we are hardwiring going above and beyond, going above and beyond for people to get them real access to care. And that's, people do their talking with their feet. Our folks, most of them, I think it's like 85%, choose to go to the Bridge Clinic because they're treated well. There's walk-in access. They come in at 4:45. That we can start them in treatment in our emergency department. Then they have a next day or within a week follow-up. We ensure they have access to medications. We've ironed out all of the problems in medicine, like getting their prescription. All of this we're trying to make easy for people. So this looks like frictionless access to care. So I'm going to turn this over to Siri here, my CEO, who has graciously agreed to talk about this from her bird's eye view as the CEO of my hospital. But I'm going to have her talk a little bit about this from her point of view. All right, Siri.
Thanks, Ariana. Yeah, thank you so much for having me here. When Ariana first asked me about participating, of course I was supportive, but I'm thinking, I'm not sure what I can add to this discussion. So I think really what I want to talk about is the culture that Ariana sort of alluded to, that the culture is what really makes a difference to hardwire all of these processes. So the first picture I have up here is, this is our hero in healthcare. So Marshall has a process where we recognize our heroes in healthcare. Anybody can be nominated. And then there's a blind selection committee that picks the hero for the year. This is the 2022 hero in healthcare. She is a substance use navigator. Her name is Carrie Herbert. And I just wanted to read a couple things because I actually had the honor of reading her nomination when we gave her award. And I have to tell you, I got choked up when I read it because it's all about reducing stigma and meeting people where they're at and really being kind. So I'm going to read a couple things off of her nomination form. So Carrie ensures that our patients know that they are going to receive compassionate care and that we're happy that they have entrusted us with their care. Carrie can be seen taking a knee to be on an equal eye level and to hold the hand of a patient experiencing a mental health crisis or opioid withdrawal. Carrie provides support and education they need to help them decide their path forward. And I have to tell you, like I said, I got choked up when I read this because it's about being kind, being no stigma, and meeting people where they're at and being ready to help them when they're ready to address their issues. And I couldn't be more proud of the work that our substance use navigators do. We've seen, you guys seen the statistics already. We've seen a decrease in our ED length of stay for these patients. We've had over 2,000 consults in our emergency department because of the great work that Ariana and her team has done. And I couldn't be prouder about meeting these very vulnerable people when they need us. It's really important to connect people up to the care that they need when they're ready. And as Ariana said, a lot of times that's in the emergency department. Next slide, please. But I wanted to also talk about the fact that this is not just a one-off, that we have integrated this service into the regular, the processes of a hospital. So we include them in process improvement, in committees across the organization. So you can see Ariana in the slide here. She's with Dr. Martin Entwistle, who is our Associate Chief Medical Officer and a social worker and one of our nurses. And really it's about making sure that this is a connected process across the entire organization. So we do, they're on various committees. They're on the quality subcommittee, behavioral health access and navigation committee. We have a navigator team. But I think the point of all of this is it's not a one-off, it's not separate. It's part of what we do across the entire organization. Next slide, please. But it really goes beyond Marshall. It goes across our entire community. So one of the things that Marshall really strives hard is to connect our services across all of El Dorado County. You know, as Ariana said, we're in a rural county. We are the only hospital on the western slope of El Dorado County. So El Dorado County has the eastern side, which is basically the Lake Tahoe Basin. And once you hit Echo Summit, we cover everything from Echo Summit all the way down to Sacramento. And you know, it's a big responsibility. It's a very broad geography that we take care of. And so we have to partner with people to do that. So we have our substance use navigators out in the community. They're on all kinds of things like we adopted sorry, I'm not a clinician, naloxone, whatever, Narcan, easier for me to say, in the schools so that they can pass them out in the schools. We helped educate people about fentanyl and the dangers of fentanyl, but it's really about that broad outreach that we do across El Dorado County with our partners, with the county, with public health, with all of our partners, and improving access to care for these very vulnerable patients. And I keep saying it like that on purpose, that it really is access to care for these people. Next slide. And one of the things that I really wanted to spend a second about is talking about that no stigma. And I think I can do this. I mentioned this to Ariana yesterday, and I will share it with all of you. My son actually has substance use disorder. That is not why Marshall did it. Don't get that impression. But I will tell you that getting him into treatment and getting them in a place where he's not stigmatized for his disease has been huge. It's been life-changing for him. He's been in treatment for 3 years. He's doing great. But it's people like the people at our CARES clinic that really make the difference for making sure that these people are treated like human beings, that they're treated with people as if like it's a chronic condition. And as a mom, that's one of the things I had to work through, that this was not just a one-off, that it was like, okay, so we're having this issue, you're going to stop, everything's going to be fine. That it doesn't work like that. It is a chronic condition that you have to continuously treat. And I had to sort of work through that myself as a mother. And I truly appreciate people who run our CARES clinic that meet people where they're at so that we can connect them to the care that they need ongoing and having them recognize like it's any other chronic condition. My other son has, he has mild autism and ADHD. And so Kobe is going to have to deal with that his entire life. And I knew that going in, but now I actually recognize that with my other son, that he's going to have to deal with this entire life. So it's about creating that empathy and that connection. We've done mandatory classes across the organization to really strive towards being kind and meeting people where they're at and reducing that stigma. So we've had classes for the EDs, the ICUs, our OB department, because as you all know, expectant mothers with substance use disorder is a challenge, and how do we help them navigate all of that? So we're really trying hard to do everything we can to meet people where they're at and destigmatize getting treatment. Next slide, please. And I think Ariana put this in here because she wanted me to just share a little bit about the fact that this is really what Marshall does. You know, one of the things that we've been recognized for is some of our external programs and our quality programs. So whether it is the Loan Institute recognized us for our excellence in care. We've got the straight A's from Leapfrog for the last 3 or 4 years in a row. We've been a top hospital for Leapfrog. And we actually got the Hospital Cal Compare Opioid Honor Roll for excellence because of the work that Ariana and her team and our CARES Clinic coordinate across the county and the work that they're doing to help these very, very vulnerable people. So I think that's sort of the point of this slide. If anybody has any questions, I'm happy to answer them, but I'm going to turn it back over to Ariana at this point and we'll be available for Q&A at the end.
Yeah, and I'm going to go through this pretty quickly, but just so we have time for our question and answer, but can this be sustainable? You know, of course, you could say, oh, this sounds really great, but how do we actually do this and pay for it? We all know that in medicine, we have to pay for it. So there's actually some billing codes out there. You know, I had some questions in the chat about navigators and how to sustain them. But the key here is wherever you are at in the country, you want to work with some key stakeholders. You want to make sure that folks know that your emergency departments want to do this, and you know, really partner with some local behavioral health programs, local treatment centers, but your hospital needs to make sure that they're advocating for this. I'll talk a little bit about some specific billing codes, so that's helpful, and you'll get a copy of these slides later. So again, I will touch on this very briefly, but the next slide. So there is a procedure code that your emergency department physician groups can bill for. It's G2213. This is billed out as a procedure code, and this is a Medicare code. So all your state has to do is make sure that this is also a Medicaid billing code. California did this. This bills out at about $58 to $60 per patient. So this is a good way to incentivize and to really acknowledge that this is complex care. And so we are able to bill for those services as clinicians. So that's very important. In this next slide, how are we trying to sustain our navigators? Well, there's actually some hospitals, and in fact, Wendy's Hospital specifically has been doing a little bit of this, and actually Cottage Hospital down in Santa Barbara has been able to do this, bill for Espert. So these are G-codes to bill for the screening, brief intervention, and referral to treatment. So there's a couple of codes we mentioned here based on time spent with a patient. And what we're hoping is that there's some, you know, we're hoping that some leaders get together and figure out some better ways to pay for this, because we know that moves medicine. And I just have to be honest, I know that moves medicine. It's placing emphasis on this. So just like, you know, when people are interested in having trauma programs because reimbursement. So if we make this something that's highly reimbursable, I think you're going to see more uptake of this, and things can be done to do that. So recognizing that there's ways out there to do this. And really what's key in this next slide is that just getting stakeholders together. So making sure that people know that these navigators are very important. I know that our navigator has already been integrated into our emergency department budget, because as Siri was talking, we've shown that her work is able to decrease length of stay, decrease readmissions. These are things, of course, that are very important to hospitals, that we're able to provide better treatment to people. And then again, you want to make sure you're engaging your clinics, manage care plans. There's some HEDIS measures that have been used to drive this care. So it's looking at all of these different levers to make sure this happens in your state and in your communities. And there's lots of ideas. I know that there's very disparate reimbursement, and that's a problem. What if when you're addressing substance use disorder in office visit, that there was a higher level of reimbursement for that? I think you would get a lot of more people who would be willing to do this, recognizing it can be complex care, that people have more than one thing going on, and addressing their substance use disorder is valuable to them. So we should put value on that as well from a clinician point of view. All right, so there's a ton of resources. This next slide, there's a QR code. We all know QR codes, you know, with COVID. So please, cabridge.org. I can tell you that we've very passionately put together a lot of resources, because we've really tried to answer every question that we've received by putting resources out there. And these are widely shareable resources. So please use these, share these. We really want to get these out there and make sure that people can start programs. So thank you for your attention. This has been great to present with Wendy and with Siri, and we are looking forward to answering some more questions. So.
Thank you so much, Ariana and Siri and Wendy. Really such fantastic information that you shared. So I'm just going to invite participants to, if you haven't already, put any questions you have in the Q&A. We have a lot of great questions here, and we are short on time, so I think we'll tag team this. I see some of them have been answered, but I want to ask first a question that you just like sort of weighed on me through this whole presentation, and that is, this is such an obvious, logical thing to do. And I shared this with the panelists before this webinar. I myself am a nurse practitioner. I worked at a major health system in New York City. And I remember distinctly a psychiatrist in the inpatient ED, in the ED saying to me, we have people who come in, they're ready for treatment, they want treatment, and we tell them to show up 3 days later downtown at an appointment. And they say, please, please don't make me go back to my neighborhood and walk past my dealer. And no matter what we tried, like a taxi, all these different things, we could not get this done. The lawyers didn't, they opposed it. So I think I would love to hear from Siri and from Ariana or Wendy, like, why don't we do this? What are the challenges? And for our audience, who I'm guessing is thinking, some of these same questions, how can we get past those barriers that seem pretty ever present?
So I can go ahead and start, and then I'll probably turn it over to Ariana. I think for me, the barrier is really just lack of education, because as a hospital CEO, I'm worrying about a lot of things all across my entire organization. So I have to worry about COVID, I have to worry about COPD and cancer care and babies, and it's a matter of educating people that substance use disorder is a disease, just like COPD or pneumonia. And we need to integrate that into our organization and do the same thing for them that we would do for anybody else. So I think for me, it's about educating and reducing the stigma, but I'm sure Ariana has other ideas.
Oh, that's absolutely true. Thank you, Siri. And so what we're trying to do is so Siri talked about the community work we're doing. We're trying to get a shared understanding out there that substance use disorder is very prevalent. We know that there's this disease model of treatment. In fact, we're doing the stigma trainings we're doing pair a portion of lived history. It's like a perspective taking exercise where my navigator shows her own story in order to humanize this, put a face on this, right? And then we do a second part where we talk about the neurobiology of addiction. She is not a bad person. Siri, thank you for sharing about your story. Your son is a good person. He's not a bad person. This is very treatable and very prevalent, and we can treat it. We can reverse the course of this. So getting that information out to the community so that we have the shared understanding that this is a good thing, that medications are a good thing. Because Carla, I have to say, initially when I started, I thought everybody would be on board with treatment with medication, like, oh, thank you. And then some people I talked to, they said, oh, I don't want to substitute one opioid for another. And it's like, oh goodness, I have some work to do to make sure people understand that it's not substituting one opioid for another, that treatment is real, that it works, that it's based in science and evidence, and that we can save lives from doing that. So making sure, I've talked to my city council, I've talked to the teachers at the school. I have the superintendent of schools on text message, him and I talk all the time. We've talked to the jails, it's really getting that shared understanding out there so we can turn the tide, because somewhere along the way, the wrong messaging got through to people. So we're really trying to normalize this in medicine. And when you take this on in medicine, it really does change that. It's like you stop with that othering. This is other people. This is our community, our families. These are our friends, so I think it's important to address.
Yeah, thank you. Thank you so much. I'm gonna shift our focus a little bit here now. And we have a participant who submitted a question to us ahead of time from Virginia Medicaid. And I know we have states on the line. And Ashley Harrell, if you're there, would love to hear you just talk a little bit about how you are all thinking about supporting bridge clinics and your approach, and any questions you might have for the panelists.
Oh, wow. Thank you. So Carla, can you hear me okay? All right.
Yes,
well,
I can.
First of all, what a powerful powerful presentation today. Thank you, Ariana, Wendy, Siri. To me, I think you nailed it. I think having this conversation attacks stigma. So just an amazing presentation today, and thank you, and also thank you for your willingness to help other states implement this model. I know in Virginia we have priority to reduce opioid fatalities by 20%, and implementing the bridge clinics is one of our strategies. So just want to share a little bit about what we are doing in Virginia. I think years ago, Ariana, you presented to us, and I think this is when we were first exploring the bridge clinics. But we're one of 15 states that were awarded the Centers for Medicare and Medicaid Services Support Act grant. And with that grant, one of our projects was working with a Carrellian clinic, which is one of our hospitals in Virginia, to expand their bridge clinic model, but also to develop a curriculum or training to be able to work with other health systems that were interested in implementing this model. Some highlights from Carrellian was that they really emphasize the role of peer support specialists and navigators, or in Virginia we call folks care coordinators. And with the grant funds, they were able to hire peers and care coordinators within their bridge model, which they said has helped to increase their positive outcomes. But also another component of the grant was funding Carrellian to build this protocol. And so the goal of this was to have 4 health systems participate in this training, and we actually got way more interest. And so through this project, we were able to successfully include 5 hospitals to implement a bridge model. And we've actually taken Carrellian's program and we're supplementing it with other funds to increase the number of hospitals that are able to receive this technical assistance. So we are not where California is, but I'm very just hopeful with this work that we're doing that we'll be able to map out and be able to show the increase in health systems that have this model. So one question I did have, Carla, I was just interested if it's okay to ask Ariana about stimulant use disorder and how you address this in your clinic.
Sure, and we actually have a couple of questions in the chat related to that, so yes.
Yeah, so stimulant use disorder. So we developed a Centers of Excellence program through California Bridge. That's how we use state opioid response funding in SOR2. And the Centers of Excellence, we call it Bridge to Meth. So we're specifically trying to help our folks with stimulant use disorder, because it's so often we see folks in the emergency department who are struggling. I will share that my sister died from the effects of stimulants, and so this is very near and dear to my heart. And actually was one of the motivations behind Navigators as well, to provide a safe environment for folks to disclose this. But what we're doing specifically is offering care through recognizing where somebody may be with stimulant use disorder. So first of all, it's complicated. It's not like we don't have a buprenorphine for stimulant use disorder. So number one, we've talked about stigma, right? Decreasing stigma so folks feel comfortable accessing care, because there's a lot of medical issues that can come up with folks who are struggling with stimulants, and we want to make sure that they feel safe accessing care. I've had people say with their stigma in the hospital that they usually utilize, they would rather lose their arm than go there. So it's really important that people feel safe going to the local emergency department and hospital. Second, we offer medications, and we see this cycle. People need to sleep. So if I'm going to say something broadly, if you remember anything, people need to sleep. I think we all know this, but I need to emphasize this with methamphetamine specifically. And so we're trying to enable people to sleep. because all of the bad stuff that we see with psychosis, overamping, a lot of that is happening through this period of time of use. We don't usually see it like first use. This is from repetitive use, not sleeping. And then of course, we see a lot of complications from that. So, so we will encourage sleep with various medications if needed. We also try to stabilize psychosis. It's so there's, olanzapine out there is what I use typically if somebody's having any kind of varied thinking, if there are any like little hints of psychosis at all, I'll give them olanzapine to stabilize that, and then even give them olanzapine and tell them, hey, if you're feeling like you're seeing things that other people aren't seeing, or hearing things, or feeling paranoid, there's different things that we can do, and this is one medication you can take if needed. So I will make sure they have a prescription of that. And then as long as their psychosis is stabilized, we will give them mirtazapine in our emergency department. There's some evidence behind mirtazapine. There's also evidence that bupropion and naltrexone work, but I don't usually do the naltrexone bupropion in my emergency department because a lot of folks are, co-using fentanyl, or there is also some fentanyl, a lot of fentanyl in our drug supply in my county. So though there is evidence behind that, then we refer to treatment. And the two main places that we refer to in my county, the FQHC and our Bridge Clinic, the Marshall Cares Clinic, both do contingency management. So that is where there's evidence as well. So they will meet people where they're at, work with them on what other substances, any other psychiatric issues, because that's very prevalent in my community. We give medications that work, we treat people well, and then we also address other challenges. For example, housing. Some people say, I can't work on meth right now because I don't have a place to stay. And so we try to work with them to help stabilize them. And I have so many stories I can tell, I just don't have time, but that would be my answer, is that's our answer to meth right now. And our follow-up rate for meth is about 30%, which is not bad, right? I mean, that's compared to 0%. so that's something. So, and we're hoping that there's more. There's a lot of studies going on right now, and we are open to, the changing landscape and how we can address this better.
Thanks so much. And thank you, Ashley. I want to turn a question to you, Wendy. And that is, it's sort of twofold. One is one that was submitted ahead of time before this webinar, and that is, how do you approach or navigate when a client doesn't necessarily follow up with a provider after the emergency room visit, or are you involved with that, or are there processes to help coordinate that follow-up care? And then I just kind of wanted to ask you personally how you measure success in your role, or when you're mentoring other substance use navigators.
So for the first question, if I see that a patient is continuing to come to the emergency room for their prescriptions versus going to their clinic appointment that I set up for them, I'll have sit down and have a conversation and try to figure out what the barrier is. Sometimes, they think that they were going to have a ride, that their, friend or someone was going to be able to get them to their clinic appointments, and it doesn't work out, that type of thing. And then I'll propose a question of if they want to try telehealth, if that would be easier for them, as long as they have a phone. And if they have our county Medi-Cal program, then our county will send lifts for appointments to get them back and forth, as long as they set it up 5 business days in advance. So then if they don't have a phone, we do that here. I do that with them, and we set it up. And so then they'll reach out to me, what if they need access to a phone or to come set up their appointments. I'll schedule a time to do that with them and make sure. To answer your second question regarding the retention rate or the successes, when I follow up with them, right now I have an Excel spreadsheet where I manually put everything in. But today at 2, I'm working with our IT department to help me extract the numbers from Epic that I'm going to need, because I just see too many patients here. And it takes me a good 3 or 4 days at the end of the month with like no interruptions to be able to get all the information in that I do. So I follow up that way. But substance use navigators will tend to have patients that we really connect with. And I have to tell you, once you treat someone with respect and dignity, they contact you. I have a Google number on my cell phone for patients that I give, and I don't get paid salary, but they have 24/7 access to me. I do not care if they call me at 2 a.m. I just ask them, if you call and I don't answer, call again, because I might have not heard it if I was sleeping. But you can text me, you can call me, and I get the most beautiful text messages from a lot of the patients with pictures with them with their children, and thanking me, and this is how many days I've been sober, and so it is like I said, it's just an amazing work, and I'm just so proud and happy to be part of the Bridge program. But that's how I document and see my successes.
Thank
and
you.
numbers.
Thank you, Wendy.
You're
Thank
welcome.
you. Such wonderful work that you do. So we have about a minute left. I'm going to turn to someone who also submitted a question ahead of time, Dr. Mo Ali from United Healthcare Community Plan Virginia. He's the Chief Medical Officer. Dr. Ali, if you can just briefly share your question, then we can have the panel address it. Dr. Ali, if you're speaking, we can't actually hear you.
Hear me now?
Oh, yes, we can now hear you.
All right. Thank you. I wanted to say that this is a phenomenal presentation. Thank you very much. I wanted to briefly call out Ashley Harrell in Virginia. The Virginia Medicaid Agency, DMAS, is doing a fantastic job in raising the bar with how we recognize and treat. My questions, I think you've already answered a big piece of my question in terms of the pearls and how do we make this work. And that certainly I'm hearing is the Navigator, loud and clear, and really important to treat our members or patients with kindness and with dignity. I'm hearing that loud and clear. But the one piece I'm still not hearing is the pearl on how do I bring emergency department docs aboard when their mindset is episodic, they treat the illness in front of them and they move on. But this requires that they think just a few steps more to secure one end of the bridge and get it in motion so that we can get members across the bridge. Any thoughts on how we do that?
Oh yeah. So I mean, that's what we're doing, like across California and across the country. And there's a narrative out there that I don't think is really correct, that emergency department physicians don't want to do this. We've proved that wrong in California. I mean, we have most of our hospitals, the emergency physicians, PAs, nurse practitioners are doing this, but it is a change in practice. And so the number one thing we did, we actually acknowledged the champions who are getting this work done. It really is best delivered from a local respected clinician. So get a champion. Number one, give them all the tools they need in order to get all of the information out there and then support them. So we actually just created an updated video on how to start buprenorphine. Alicia Gonzalez did this. It's on cabridge.org. We pair it with, here's a slide set. Your local champion can give this talk at their meeting. So we have found we want to build leaders, and what was really effective in California and what we're focusing on across the country is building leaders, because I can tell you all of us got into medicine to make change and save lives, like really, like that's what we want to do. But we've been given some information that's been misinformation for years, that this is somebody else's issue, that this is a moral failing, that all of these things. So we have to change that. And I think it really does happen locally. Always happy to talk about that. That's what I am doing right now, very passionately. And there's also just, you're going to get 30% of people who are like, this is a great idea. You're going to get probably about 50% who are like, okay, if others are doing it, I'll do it. And then you're always going to have that last, 10 to 20% of people who are like, nope, this is a bad idea. And the way we get to those is improving quality measures, making sure that we integrate this into expectations for hospitals, and we will get the last 20%.
If I can jump in on
Thank
that as well. There was a lot of stigma when I first started at Arrowhead. I'm now at Loma Linda University Medical Center, but when we first at the inception of the program, and there was one particular physician that was like, nope, I'm not doing it. And then once he's seen all his colleagues participate, and he started to see the change in the patients, and he realized that I was following up and that we weren't seeing these people come in anymore, he jumped on board. So sometimes it's just the growing atmosphere. It'll start with one or two and it trickles down because they need to see it sometimes and see it really truly is a transformation when somebody is induced on buprenorphine. You just see it on their they just change. So that always works too.
Thank you. I wish we could, have another half hour here, but we are at time. So first of all, I just want to say it was such a tremendous honor to speak to you all, Ariana, Wendy, Siri. Just thank you so much for sharing and all the tips and tools that you have provided. I want to say to our audience that if any of you have helped develop evidence on what works for caring for adults with complex health and social needs, we would welcome you to submit any resources and ideas that we can include in the Better Care Playbook. And you can go to bettercareplaybook.org to do that. I also would like to encourage you to all fill out the evaluation survey at the end of this webinar. We really value your feedback, and it helps us think about what we put out for future Playbook events. I'll just close and say thank you again to our presenters and guests who shared such wonderful insights. Thank you also to the 7 Foundation Collaborative for making this webinar possible, and everyone who joined us on the webinar today. And for those of you who shared questions, thank you. And thank you so much. Have a wonderful day.
Thank you so much for having us. That was really fun. Thank you.
Thank you.